Today on the podcast, we had Dr. Hirsch, who is a retired doctor now and is currently just working in medical billing. So if you don't understand RCM or the United States billing system, hopefully you can watch this episode and have a better idea. Hopefully you enjoy. Like, what do people not understand about coding? That's like the first question.
I think the biggest thing people don't understand about coding is that there's no fear in coding 99214s and 99215s. We honestly feel like there's an allergy or like this reluctance to code appropriately for the work that you've done. And so I think that's honestly the biggest thing that I see.
And what is that? But what is a 9.0? Like what does it even mean? Like to get
So
started?
those are what they call evaluation and management, E/M, E&M codes, and that's related to the work that you do in the clinic or an outpatient setting. So those are the outpatient codes.
And what people are afraid to do outpatient codes?
They're not afraid to do them. They're afraid to code appropriately. So they kind of go that here's what happens. They do a level 5 service, which is a fairly extensive level of service. They document to a level 4 service. They code to a level 3 service because they kind of go, I don't want to get audited, so I'll just code a 3 and move on. And so they're leaving $100-ish on the table every time they do that.
And they shouldn't be doing that. They should be just go big.
Absolutely. Document appropriately and code appropriately. Code for what you did so you get paid for what you did. That's our motto.
And what causes denials in coding?
Typically what causes denials is lack of documentation. So somebody might code a level 4 or 5 service, but they don't actually have the 1 or 2 phrases that will actually guarantee that that level of service is appropriately documented. And so the insurance companies will either deny it or they'll just downcode it automatically. And it's usually because the documentation isn't there. And when I say that, people hear, oh my goodness, I have to do all this more work. I'm already on the computer till midnight. I don't want to do more work. But the fact is, it doesn't take a ton more work. It just takes putting in the correct phrases to make sure that the documentation will stand up, and then you should be good to go. But I think that's the biggest cause of denials.
And we've been here at Caesar Health, we're an AI company, shameless plug. We've been talking a lot about building like note takers. Do you advise your clients to use note takers?
I actually think they can be really useful if they're used correctly. So, for example, I was just doing a training yesterday and we were talking about this because one of the physicians said, when I use my AI scribe, we talk about a lot of things and it catches that in the note, but it doesn't make an assessment and plan for that. Well, that could be your chronic stable condition, and you only need to have 2 of those with prescription management for something, and there's your level 4 service right off the bat. So sometimes it doesn't catch those things. The other problem I see is because you also can get credit for what you've considered, but not necessarily did because the patient maybe declined to do it. If you document that, that counts towards your note. So again, another example, like a patient who maybe you want to give them an anti-inflammatory drug, but because they have hypertension, heart failure, chronic kidney disease, you choose not to even offer that because you kind of go, that's probably not a great choice. If you don't say that out loud, AI can't pick that up and AI can't get in your head. And so it's going to miss that, but that also is going to raise up that note to a level 4 service. And so if you don't actually go back and add that in yourself, AI can't pick that up. So I think those are the pitfalls, but otherwise, honestly, most AI scribes do an amazing job, and they actually put too much information in sometimes, but I think overall it's really good and you can just edit things out.
Why has no one merged AI note taking with revenue cycle management then? Because the codes exist. I can't name them on top of my head. Why not just have a note taker and these codes and kind of merge them together so the note taker understands what the code will be and produce for the code?
I think that's a job for companies like you.
But why has no one else done it? I don't understand.
I
That's
have
kind of
no
what
idea. I wish I could have a crystal ball and say, this is where the money's at, is really if you can make that interface between what happens in the exam room, what gets documented, and what gets coded and billed. I think that would be amazing. But I don't know that that software exists. Maybe it does, and we don't know about it. But I agree.
someone's
That's where
probably
the
building
money's
it.
at. Yeah, absolutely.
Um, so then when it comes to coding, we kind of talked, documentation. What is the hardest thing to code for insurance in the United States, would you say?
I'm not sure what you mean when you say hardest. What are you referring to?
Like, what's going to get denied? Is there something that's very hard to pass by insurance? For example, I know experimental medication can be very tough to get approved with certain insurance plans.
Mhm. I think typically it's going to be your level 5 visits where you don't actually document the thing that makes it a level 5. So, for example, if you have a person who's on a high risk medication and you don't call out that it's a high risk medication, your coder, your biller, an auditor at an insurance company, they may not understand that that's a high risk medicine. But if you call out that it's a high risk medicine, that's going to get you that level 5 service. But if you don't call it out, that may get missed and denied. So, I think that's one of the things. And then I think also sometimes if you're coding based on time, but you don't put the time down, that's a
Hmm.
problem because some people believe they can code based on time and then they forget to put the time down. Well, that doesn't make a lot of sense. So making sure the time is there if you're going to code based on time and making sure that the phrases are there that warrant that level of service. Another example is for a 99214, making sure you have the social determinants of health in your note, having that be in there someplace. Again, if you call that out, that this is a social determinant, as opposed to just having it randomly someplace in your history of present illness, I think people will see that and understand, oh, that makes it a level 4 service. But I think people don't use those phrases. And so I think that's what typically gets missed. Now, I'm not going to say that they wouldn't be defensible. Once they're denied, you could go back and say, well, here it is, and it would go through, but you're going to have an extra, 3 or 4 or 5 week delay in your revenue cycle. So, exactly what we were talking about earlier.
And how many levels are there in the system?
There are a million codes, not really a million, but the ones typically for outpatient is 992201, which is a new patient, to 99205, all new
Hmm.
patient codes, and then 99211 up to 99215 for an established patient. So there's basically 5 codes for each. The ones are for nursing visits, 2 through 5 are for physician visits, but twos really should never be billed, in my opinion, and rarely threes. But
Why
yeah,
should
and then
twos
there's
not be
a ton of,
billed?
I'm sorry. Well,
Why
those
should
those
twos not be billed?
basically those basically are things that are so minimal that they almost never qualify for a 2. They're almost always a 3. It's just that if you actually look at the requirements for a level 2, most things are beyond that. So I can't even imagine a time I ever coded a 2 in my practice.
Mm. It's
But
just
then there's lots
redundant.
of, oh, I apologize. I was going
No,
to say
sorry,
there's
go
lots
ahead.
of other codes. So there's G2211, which is a longitudinal care code. There's the transitional care codes for transitional visits. So there's a fair number of visit types that just standard, physicians in the office are going to code. Of course, there's procedure codes, there's modifiers, there's all kinds of other things that we do, but those are probably the bread and butter for most people.
And do you think that coding is complicated on purpose? I know people kind of accuse insurance companies of making coding complicated to try and get denials. Do you think that's a reality or no?
Absolutely, it's a reality. They make it particularly difficult and hard to understand. So unless somebody actually explains it to you, it's very easy to just feel like, oh, I don't really understand this. I'm just going to code a 3 and move on. I can tell you a story about what an insurance company did. This was years ago. They may still be doing it. They have a whole division designed to specifically not pay doctors, and their budget is $1.5 million. And they basically were sending out the checks to the company, to the clinic, and the checks would
Mhm.
be black and white with some other stuff on top. And there was a perforation, and you were supposed to pull that check off. But to most people, because it was in black and white, it looked like a copy of a check. So they would just file it away in their file cabinet, and then later we'd come in and do some consulting for them and pull these files out and say, well, these are active live checks. Why haven't they been deposited? But they did that purposely so people would not catch them. And because they don't know, because they say, well, of course we paid you, there you go. So there's all kinds of tricks that they use to try to not pay doctors. Absolutely.
Wow, that's crazy.
Isn't it?
Are there some other tricks that you can share?
I don't know any other tricks specifically like that, but I do know that if you want to get paid appropriately, just be sure your documentation holds up to the level of service that you're claiming, and you should be good to go. You don't have to worry about audits because I think that really is the fear that's driving people. And MGMA puts out a standard of kind of where your coding graph should be in terms of 99213s, 4s, and 5s, and typically that peaks at a 3. It should really be peaking at a 4, but it's irreparably damaged because everybody undercodes because of fear of audits. So we need to scoot that curve to the right a little bit. And I think until people understand that and, start coding appropriately, we're never going to be able to get credit for the work that we do.
And let's say you do get audited. Like what does that mean? What does an audit look like?
An audit basically is where somebody from the insurance company comes in and they may review specific charts, but they'll often just take a random sampling of 20 charts per position or whatever they choose to do. And they will go through and kind of make sure that the documentation stands up for the code that was coded. And if it's not, if it doesn't, they will say, oh, great, you owe us X, Y, or Z number of dollars, and they'll ask for that money back. And again, sometimes I think they do it specifically. Maybe, for example, they might audit all the 99215s, for example. But sometimes it's just a random audit that they do on a regular basis, as opposed
Mm-hmm.
to we think there's a concern here and we're going to go in and do a specific audit.
Mm-hmm.
They don't happen very often.
But if it does happen, it's probably not a good thing for the clinic, I suppose.
Well, not necessarily. Again, I think what we say is, when we do our medical coding training, we know that the codes are going to go up and we know that that's going to be a red flag for the insurance companies. And we tell the clinics, as long as your documentation is there, which is what we train, as long as it's there, you don't have to worry about an audit. So people have this fear of audits, but as long as your documentation holds up, you really don't have to fear an audit because it's all there. You can prove it's there and it's all legit. You're not trying to defraud the insurance company.
Mm-hmm. So when it comes to insurance, like you have like United, Blue Cross, et cetera, but then there's also Medicaid and Medicare.
Mhm.
Do you bill differently to Medicaid, Medicare than to one of these other insurance companies?
Not really. The coding is all the same, except for there are certain different ways that you might code a wellness visit or a physical for Medicare, Medicaid, but basically the coding is all the same. The reimbursement is significantly lower per RVU for Medicaid and Medicare, but
Mm-hmm.
basically otherwise the coding is the same. So at least that's good. You only have to learn the coding once and then you're good to go.
But Medicaid and Medicare probably don't have the same resources. Like, would you ever get audited by Medicaid or something, or no?
Oh, absolutely. Those happen. Medicare audits happen not frequently. I work with a group in town that's been in existence for 16 years, and I think they've worked with millions and millions of well, I shouldn't say millions of clinics, thousands of clinics, millions of doctors, and I think they've seen one Medicare audit. I mean, it just doesn't happen very often, but everybody has this huge fear that it's going to happen.
Mm. There's been a lot of talk about fraud recently with Medicaid and Medicare
Mhm.
in the United States. Do you think it's like a moral panic? How real do you think it is?
I think it depends on where you look. I think there are definitely places in the country that are absolutely defrauding Medicare right and left. They have, addresses of clinics that don't exist. They're billing for all these things. They're billing for durable medical equipment that the patient doesn't even need or doesn't ever get. They're using all kinds of fake information. I think that happens, and I think that's what needs to stop. The actual number of clinics that are defrauding Medicare, in my opinion, again, I don't know exactly, but my opinion is that would be extremely, extremely small. I think most doctors are trying to do the best thing they can for their patients. They're trying to be honest. They're trying to document appropriately. They want to do a good thing for the patient. And I think they worry about Medicare audits, but those are not the people that Medicare needs to go after, nor do they usually go after. It's the people who are, obviously defrauding Medicare. And there's plenty of those out there, believe me.
Wow. Yeah, I was I know that there's a couple of places there's been in the news and all over the country, not just in some states. So
Mhm.
then what do you think the future of Medicare is? I know that people say Medicare is probably going to be insolvent in like 10 years. Is it dark?
Well, you're asking questions that unfortunately I don't really have the answers to. I'm not the expert in this field by any means, but I do think that the system is broken, irreparably broken in general, the commercial and the Medicare and Medicaid system. And I do hope that something happens to change the system because you can't continue to decrease the payment for Medicare and Medicaid when the population is aging and these people are requiring more and more services, and yet the reimbursement is dropping every year. Clinics can't stay solvent. Their overhead is going up, the cost of living is going up, and the Medicare and Medicaid reimbursement is going down. I don't think that's sustainable. So I think something needs to happen. What that is exactly, that's beyond my pay grade.
Yeah, that was going to be my next question for you. Like if you could improve US healthcare, how would you do it?
I honestly think, I know there's a lot of people who aren't in favor of a single payer system, but I honestly think that may be the answer because it takes away all the craziness that's happening right now with the varying payments. For example, one of the things that happens all the time is depending on the size of your clinic, you'll go to an insurance company and you'll negotiate a rate for your clinic. So an RVU is going to be equal to X number of dollars. Well, the guy down the street that has a much bigger group that has much more clout with the insurance company, he may get twice that for the same service that you're providing. and the RVU is worth twice the amount that I get. Well, is that really fair? And I think that's one of the things that starts this whole process. And so I think if we all are doing the same thing and everybody's getting paid the same, and Medicare and Medicaid have enough money to be funded, I think that may be the answer. Again, there's so many, subtleties and things that need to be addressed in that, but I think that's honestly the answer.
Mm. And if you met someone who knew nothing about American healthcare, how would you explain a relative value unit or RVU to them?
Wow, I've never had to do that, but I would say a relative value unit is a number that's been assigned to a work unit. So basically, a relative value unit has to do with the work that's done in the clinic by the physician. There's a small component for actually overhead costs for taking care of that patient. There's a small component for malpractice. So those things all are rolled into what they consider an RVU. And so a relative value unit is going to vary depending on the level of service. It's around two-ish for a level 4 service. It's three-ish for a level 5 service. And it basically increases depending upon the level of malpractice involved, for example, and also for the level of service that's provided. So, for example, a neurosurgeon who performs a complex neurosurgical case is going to have a very high number of RVUs as opposed to somebody who sees a patient in a clinic for a sore throat. So it's all just based on the kind of work units of what it takes to take care of that patient.
And I want you to spill the sauce. What's the lowest RVU unit from all the clinics?
Oh goodness, I don't even know. That would probably be a 99211, at least for E&M codes for doctors. And I have no idea what that's worth off the top of my head. I could look it up, but it's pretty low RVUs. That's a nurse
And
visit for established
so a
patient.
nurse visit is the lowest RVU. And do you think this is like it sounds really bad on paper?
Yes.
The idea that the medical industry has like a value unit that's
Hmm.
assigned.
Hmm.
I think
Yeah,
so,
everything's rated based on its level of severity, level of, what the malpractice risk is, how much it took to take care of that patient, all of those things are wrapped into one. So yeah, it's pretty complex.
so how do deductibles work? Like you have your deductible.
Hmm.
How does it work? I always get very confused by this like deductible
Hmm.
premium.
So, on a very high level, deductibles basically are the amount of money the insurance company wants the individual person to pay before they actually kick in and start paying. So, for example, if you have a $3,000 deductible and you go to the doctor, generally your routine maintenance care for most insurance companies will be covered. And that doesn't go towards your deductible, it's covered 100%. So, like your GYN exam for a woman, your mammograms, your pap smear, that kind of
Mhm.
thing. But if you go to the doctor for, let's say, diabetes management or heart failure or atrial fibrillation or whatever problem you might have, those visits are all billed and go towards your deductible. So until you've actually paid that $3,000 out of pocket, your insurance company is generally not going to kick in anything. And then after that 3,000 level, then depending on your insurance company, it's going to kick in and pay usually 80% of the charges, and you'll still be responsible for 20% of the charges. There is usually a stopgap. So let's say, for example, when you meet $6,000 out of pocket, then everything is covered at 100%. So that's what protects people when they have a catastrophic thing that lands them in the hospital and they have a prolonged stay. They'll only have to
Mm.
pay that max of $6,000, not $100,000.
And what mandates that? It's like a federal thing or?
I'm not sure how that's mandated exactly. I just know that each insurance company has their own levels of kind of what they offer, and that depends on what the actual cost of that insurance plan is. So, insurance plans that have lower deductibles have higher premiums. It kind of goes hand in hand.
That's crazy. And this is basically like your sort of retirement almost. This is like the thing you've decided to dedicate your, now that you're out of, you're not working to practice. This is like what you've decided to go for.
I know it sounds kind of crazy. I call it rewirement, not retirement. So I did internal medicine for 32 and a half years, and now I teach medical coding. I do physician coaching. I work with people that have any issues, particularly behavioral and communication. And I just completed doing 11 years of peer review at my local hospital and for the state of Oregon. So it's definitely not retirement for sure. I call it rewirement.
So, and of course, I said that satirically, obviously.
I know.
So let's talk about the peer review. What was it like doing peer review?
Really eye-opening. I learned so much. It took me a few years to actually get good at what I was doing, but it's interesting when you hear about what's happening in the hospital and how physicians act out, so to speak.
Mm.
Typically when we get a physician who it comes before the peer review committee, it's 90% behavioral issues, maybe 10% clinical issues. But, again, 99% of the time, that person is experiencing some kind of burnout or, kind of they're struggling with something that leads them to behave that way. Because most doctors don't go to work saying, who can I yell at today? Who can I harm today? That's not their goal. It just comes out when they're feeling stressed or
Mm.
anxious or they're concerned about the patient. The patient in the OR is crashing. That's when they tend to lash out because they're stressed, they're frustrated. And that's all human response. It's just a matter of kind of learning how to kind of maintain your composure and maintain an appropriate level of communication with people that are trying to help you. But those are the things that we typically saw in peer review. And some were egregious enough that ultimately led to the physician being removed from the medical staff. Thankfully,
Mm.
that didn't happen very often. Most people are rehabilitatable.
And then you did mention as well, like with coaching, you're coaching physicians who have like anger management issues or.
Well, kind of, not really. So I coach on any topic. I coach on burnout. I coach on not closing charts in a reasonable time frame. I coach on leadership development. I coach on patient satisfaction scores, anything that people bring to the table. But my
Mm.
particular area of focus, and I think this comes out of my peer review work, is I like to work with those physicians who have behavioral or communication issues. So, for example, on the peer review committee, sometimes when we had a physician who was struggling with one of these things and had come before the committee, we would suggest, I think you really need to have some coaching. And we would encourage that person or mandate, depending, to do like 12 weeks or 3 months, or excuse me, 6 months of coaching to actually work on these issues because sometimes doctors don't really understand how they're perceived by others. They're just trying to do their job. As I said earlier, they're trying to do a good job. They're trying to do the right thing for the patient. They just sometimes don't realize how they come across to other people. And so
Yeah.
helping them see that and helping them be able to kind of rein that emotion in and actually respond in an appropriate way, that's the work that I love to do. It's very
Mm.
rewarding.
And then you mentioned as well physician burnout, which is it's always an interesting topic. Like, how would you help someone with physician burnout?
It really depends on what's driving that. So I like to start with it when I work with a physician. We start with what are your values? What's important to you? Does your current situation at work, does that align with your values? Because if it doesn't, we got a big problem and we got to figure out how we can make those two things align. And I think sometimes just starting there and trying to figure out what is working and what's not working, what's negotiable and what's not negotiable, and then kind of figuring out where to make changes. Honestly, for many, it's just about setting boundaries and sticking to them. I know for me in my practice, I would set boundaries and then I'd be the one to break them. I'd say, no more patients for today. And then they'd call, can you see one more? Okay, okay, I'll
Mm.
do it. So sometimes it's just a matter of setting boundaries and sticking to them. And that actually alleviates all that stress and fear and feeling of, the complex of I need to take care of everyone that they put in front of me. And I need to martyr myself and give up my family life and my own life to take care of these patients. And I think sometimes it's very simple, but it's not easy.
Mm. So yeah, it just comes down to work-life balance.
Exactly,
I
which is tough.
I think that, and I'm a little biased, when AI gets involved in practice, either there's two futures. Either you can see more patients and nothing changes. You actually have more patients, and that where your work-life balance could even be worse. Or there's like the utopia where AI makes everything amazing and no one burns out and all is well. So we'll see. We'll see what happens.
Let's go for
Um,
number two. I don't think that's
hopefully,
likely,
number two.
but let's go for that.
You have like an insane RVU and you just see like 100 patients and your AI just.
I do think that's a fear because it does in some ways make things easier, but you also have to go through and review everything that AI does because I don't know that it hallucinates a lot on medical notes, but there's definitely stuff that can end up in your note that's not really what you intended or what you actually did for the patient. And sometimes even AI can't pick up which one the doctor is and which one the patient is. And if there's another person in the room giving history, that person kind of messes it up. And so sometimes
Yeah.
I
Yeah.
remember one time with AI, I was telling my patients I was retiring from clinical medicine and AI picked up that the patient was telling me that they were retiring. And it's like, no, no, you got that all backwards. So I think we
Yeah.
do have to be careful. And so when you say, oh, you're going to see 100 patients a day because you got AI to help you, that's not realistic.
Yeah. It's a fair point. I think it really just comes down to AI just improving more and more. And just like we said earlier, with just getting AI and revenue cycle management merged to some level. Um,
Absolutely.
I have such a funny question for you. So we have all these shorts on the channel, on the Caesar Health channel, and we do a lot of like prompting and research on them. And one of our topics we've covered on these shorts is like pajama time.
Oh yeah,
And and is that actually like a real thing? Do people actually call it pajama time?
absolutely, they do.
Because
Yeah,
I
it
thought that was
refers to
just
the
kind of like not
no,
real.
it's very real. So it refers to the time that you come home from work. For me anyway, I would change clothes, get in my pajamas. I would put something in the microwave to eat for dinner. I would bring it up in front of the computer. I would eat in front of the computer, and I'd be on the computer till 11 or midnight. That was typically when I finished, was 11 or midnight every night. That's pajama time. And it's a real
Wow.
thing, and it happens, and it exists, and it should not be going on. It really kills work-life balance, and it kind of really gets in the way of family time and things that are important, especially when you've got young kids at home.
Wow. Yeah. I mean, I can totally imagine why you'd have physician burnout if that was the reality.
It is for many people.
Yeah, we don't like to keep these podcasts too long. We're kind of at time. Is there anywhere people can find you, add you on LinkedIn?
Yeah, absolutely. I am on LinkedIn. It's Anne, A-N-N-E, M as in Mary, Hirsch, Hirsch, MD, and I'm on LinkedIn everywhere. My coaching website is www.physiciancoachingwithanne, that's Anne with an E.com. So I'm there too. And really, my information is pretty much everywhere on the web. So you can find me pretty easily. And I'd be happy to have conversations with people, even if they're not sure if they need coaching, or even if they're not sure they need help with coding or billing, whatever. I'm more than happy to have those conversations just to see where you're at and see if I can help.
Yeah, it was nice chatting with you.
Nice chatting with you as well.